Have you ever been frustrated by a medical bill? What you don't see behind that complex bill is the even more complex relationship between care provided and actual reimbursement. In the next few minutes, I want to explain to you how medical care is paid for. Not who pays for insurance, but how actual care is paid for. You may be surprised. Some say that U.S. healthcare is a free market. But is it? In a market, one person supplies a product or service, and another pays some price in return. Both individuals judge the balance between value and cost. We can understand that exchange. We can also understand the exchange between an individual and an institution, such as a large employer. The employee supplies work and the employer pays a salary. Here, you will begin to see the absence of such market relationships in our healthcare. Rather than all salary, some of this payment will be paid in benefits, such as health insurance premiums paid to the guys or gals in the dark suits. Now, what happens when that employee has a medical concern, let's say knee arthritis? The employee becomes a patient and will see a doctor. They will generate a plan. The patient may pay some token copay at the visit, but most of the price for that physician's services, time, and thinking will be paid by the insurance company using a complex set of codes. If the physician offers some sort of surgery as treatment, in this case a total knee replacement, they will begin a totally new episode of care. But the surgeon can't do this alone. At the very least, an anesthesiologist is needed to help the patient sleep safely. Few would sign up for surgery without anesthesia. Both the surgeon and the anesthesiologist will be paid by the insurance company, not usually the patient. The insurance company will pay them according to codes or numbered names for each procedure. These codes have nothing to do with value. They have little to do with difficulty or time involved in the procedures. They take no account of how successful the procedure is in the end. They are generally non-negotiable for any given case. Each code will be paid some dollar amount, different from every insurance company. Physicians also use other expensive supplies. A hospital will provide the space and skilled nursing support for the surgery. An implant manufacturer will provide the implant, in this case, a total knee replacement implant. A pharmaceutical company will provide the drugs used by the anesthesiologist. We hope all these products and services provide real value to the patient. However, whether they provide value or not, the patient does not directly pay for any specific cost incurred in most cases, despite what your bill may show. No, the patient works for an employer who pays premiums to an insurance company. The insurance company pays separately to the surgeon, the anesthesiologist, and the hospital, all based on the name of the surgery performed, not how long it took, how successful it was, or what it cost to provide. Just like the physicians, the hospitals are paid by these same codes. The hospital then pays for drugs and the implants. Remember, they will not get paid specifically for any implant used, despite what the bill you see may say. One might think that all this comes out in the wash, but the implant, especially in the case of a surgery like total knee replacement, is a very expensive piece of the overall cost. The implants cost much more than the surgeon's fee for performing the surgery. Is that cost controlled by a market? No, at least not by any recognizable market relationship. Let's just look at the implant cost itself. Remember, the surgeon will choose the implant. The patient will either benefit or not from the specific implant choice. Neither pays for it. The hospital, who has little say in most cases about the implant choice itself, will pay the implant company for the implant. That actual cost will not be reflected in what they are paid by the insurance company. There is never a normal market relationship with two individuals exchanging value and weighing it against cost. Without any real market relationships, you can easily see how costs have spiraled out of control. When no one making the decision to pursue a certain service pays or even has any clue about what it costs, expenses proliferate. Some say that the solution is a single-payer system. Believe it or not, we have something like a single-payer system for our seniors in the U.S. Not all, but many Medicare patients are in a system that works this same way. Rather than premiums paid by an employer, Medicare is a tax paid by employers and employees. Rather than insurance company officers, there are bureaucrats who make the payments, but all the other elements are the same. When Medicare really got rolling in the 1970s and 80s, medical costs increased. They increased because no one choosing or receiving any service paid for it directly. Unless the bureaucrats limit what care can be provided, the costs can only grow. Canada provides another example of a single-payer system. Canadian healthcare is based in provinces, not at the federal level, but most of the provinces are fairly similar. They are all similar to Medicare, with one slight adjustment. They still pay physicians according to codes of procedures performed. But rather than paying hospitals fees based on each surgery performed, the Canadian bureaucrats give each hospital a budget for the year. They therefore limit how many surgeries will be performed by limiting space, nursing support, drug and implant budgets. All these things help a bit in cost control, but do not remove the odd lack of a recognizable relationship between services and paid costs. The United Kingdom's National Health Service Trust in jolly old England takes this a step further. There, the government owns the hospital and directly employs the surgeon and anesthesiologist. This consolidates a lot of power in one place. So maybe there we can squint and imagine a consumer-supplier relationship between a patient and the government. But on one side is an entity so generally non-responsive to an individual that only voting or riots have any hope of impacting their opinion. Further, there are few choices an individual can make in terms of coverage options. HMOs, common in California and Oregon, but less so in the rest of the United States, are very similar to the UK system. Of course, premiums rather than taxes are paid to the insurer, but they still own the hospital and employ the physicians. In every one of these systems, there is one relationship a patient can control to some extent. At some point in every system, you will speak face to face with a physician. You need to get that conversation right as best you can. Don't let it be too dogmatic or cut and dried, because the information relayed is certainly not as cut and dried and confident as it might sound at first blanch. Learn how to talk to your doctor. Learn why to talk to your doctor. I promise, my book is not about the crazy finance side of medical care. The book is about this critical interaction between physicians and patients. Read it and join your own medical conversation.